if we need to change it for future sessions, we're all sorted. Right, okie doke. So, good evening, everybody. Thank you for coming. My name is Jeanette Welsh, and I'm the lead for safeguarding adults at Gloucestershire Hospitals. But more importantly, for this presentation, I'm the education lead on the board of the Faculty of Emergency Nursing. So my brief today is to talk to you about portfolio development. Now, the reason I'm on for portfolio development is that for 16 years, I was a practice development nurse for unscheduled care at Gloucestershire Hospitals, and I've got my hello, Ros. And I've got all my my staff doing FEN competencies. So Gloucestershire staff just kind of think this is normal and are well used to me telling them they've got to get their house in order and get their portfolios signed up. Okay, so let me share my screen and then we'll carry on with the presentation. Now. Right, can everybody see my screen okay? Yeah. Fabulous. Okay, just before we start, housekeeping stuff, so webinar information. This session is being recorded, isn't it, Judith? You pressed the button.
Yes.
Fabulous. And it's going to be made available on the website for catch up for anyone who missed it. Can you please keep yourselves on mute? I can see that most people are on mute now, which is wonderful. Everybody knows how to do these webinars. Keep on mute unless you're speaking, because otherwise it causes an echo and interruptions. If you want to speak on Zoom, the quick way to come off mute is to just hold down your space bar. If you want to ask a question or to add a comment, then if you use the chat function, Judith will alert me to the fact you've asked a question or made a comment, and we'll aim to answer all questions and follow up the chat later on. We've found with practice that if your reception starts to feel a little dodgy, the thing that will help is turning off your camera so you don't have video on. Certificates of attendance will be forwarded. We've got a QR code which you'll need to zap at the end, and that will get you your attendance certificate. We're trusting you not to share the codes for the sessions or the recordings unless you've had permission to do so. Okay, so portfolio development. Right, lots of different types of evidence. So this is going to be in a qualification accredited with Agorid in Wales. And Agorid is an open university type arrangement for vocational qualifications. I'm going to use as my example the adult and older adults unit, because that's slightly easier to work my way through. I'm very familiar with that, having done it with a lot of my staff over the years. So before we can award you with an AFEN qualification, you will need to have built a portfolio of evidence, and you will need to have had your resuscitation skills tested in practice. The easiest way to do that in the UK is to do an ILS course, an immediate life support course, but in other countries there are other options available. You'll need to speak to your resuscitation trainers to see what's the best option, and anyway your department managers may well have that all in hand. So in addition to that, you will need a mixture of analytical reflections, DOPS, mini-KEX, and multi-source feedback. Now, I'm going to translate all of those terms for you, so don't worry about what's that. Oops, that animation didn't work. Let's start with the written work. So the first thing we'll be expecting to see is 6 focused analytical reflections on the care you have delivered. Now, the mistakes that folks make with these things is that they do an awful lot of the doctors did and the doctors didn't. These portfolios aren't about what the doctors did and didn't do, the decisions they made. They are about your nursing care. So the most important thing to note is that these have to be about your care. We're going to need a mixture of case reviews and annotated notes. Now, Judith does a separate session on how to annotate records, so I'm not going to spend any time worrying about that tonight. And case reviews, I'm sure everybody has done something called a case study or a case review at some point, but I'm thinking on the hoof here, Judith, that probably we need another webinar on case reviews. You will need anonymised and verified patient records attached to those. Now, be very, very careful with these. A quick way to not pass is to leave it easy for your assessor to track down exactly which patient it was. All the regulatory bodies require you to produce anonymised patient records. So you can't have anything that names the patient, you can't have anything that gives the patient's address, and you can't have anything that gives the patient's NHS number or hospital number or date of birth, because somebody who knows where you work would very easily track the patient down if you gave them any of those pieces of information. Give them 2 pieces of information and they'll have it very quickly. If it's my staff, and they leave me 1 piece of information and I can find it in about 10 minutes. So that's really, really important that all notes have to be anonymised. The second component to that is verified. Now, verified means that somebody in your department has signed that to say that you looked after that patient and that you are not just making it up. We can't have tall tales. It's got to be someone you genuinely have looked after. So given those limits, in an ideal world, we need patients from different decades. So if you're working with the adults and older adults, that means someone in their teens, someone in their 20s, 30s, 40s, 50s, 60s, 70s, 80s. We don't want just people in their 60s or people in their 80s. It's got to be a mix. And the main focus of those has to be on 6 different body systems. It's your choice what the body systems are, but they have to be 6 separate body systems. And what's that about? That's about stopping you doing 6 acute MIs or 6 lots of sepsis, because we just need to see 1 lot of that. We don't need to see 6. So they've also got to include safeguarding and domestic abuse, intimate partner violence, and how you would screen for that and manage it. And that's for statutory reasons. Everyone has to inquire about safeguarding. We've got to keep people safe from harm caused by abuse or neglect. And so that needs to be there. And we need 6 issues presented. So I'm going to move on to that on the next slide. Is everyone happy with that so far? Any questions at the moment? That's just 6 bits.
There's nothing in the box.
Lovely. So the situations that have to be covered by reflections are, come along, an adult with critical injury or illness. So that's not too difficult. We can all think of several of those: an acute asthma attack, a compound tib fib. An adult where you've got reason to question their mental capacity. That's not too difficult. That's perhaps someone with a disability or somebody with delirium. Notice that it's an adult, not an older adult, so don't come telling me it's dementia when they're 32, because that's unlikely. But it might be a brain injury. Acquired brain injury does happen that young. And an adult with an urgent endocrine problem. That's because we all know there are unrecognised issues with DKA, with diabetic lows, as we've now got to call them. And we also know that steroid-dependent patients get a pretty rough ride, so it's good to be across the steroid dependency. An older adult with sepsis, because sepsis is very prevalent, and an awful lot of our patients who come in with sepsis are already in the older adult bracket. An older adult with dementia, and a frail older adult. So you'll have noticed there that 3 are adults and 3 are older adults, and that is deliberate. So those situations have to be covered by the reflections, but you could find that more than one thing is covered by a case. So for example, you might find you've got someone with learning disabilities with a compound tib fib fib, who also happens to have a DKA. Unlikely, but possible, and that would cover all 3 of those adult ones in one case. We've got some performers to help you with this. The first performer is a DOPS. So you remember that was my second item down on my first slide. Now DOPS stands for Demonstration of Practice. And the sort of things that we'd expect to see a demonstration of practice for are these. We need to see that you're capable of managing observations, ECGs, pain assessment and scoring that properly, IV drug administration, venipuncture, cannulation, catheterization, plastering maybe, and all those sort of clinical skills. What do you already have that could demonstrate your practice? Because I suspect that people have these sorts of bits of evidence already stashed and simply need to get them out of the box or blow off the dust or go up in the loft and get them out, and could then populate a portfolio already. Does anybody already have something that could demonstrate those sort of things?
Our specialist practice postgrad, probably the portfolio for it would be quite similar to this, I think.
So you might well be able to reuse that evidence. You know, if you were assessed as perfectly competent at catheterization, there's no reason why you would stop being competent at catheterization. You just need to kind of mention in dispatches that you catheterized the patient. Please see assessed demonstration of practice form. Other performers. Sorry, did someone want to say something?
Sorry, Jeanette, it was just Caroline. I just wanted to say, do you know as regards the IV cannulation, or the IV, venipuncture and cannulation and things, if they've already got for that and it's signed off, that can be used then as well?
Of course, yes, of course. Yeah. And it's the sort of thing that I would set my staff as they kind of a quick homework. You know, right, your homework this week is you've got to go and rootle out the box or the dust-covered pile on the windowsill or up in the loft or the file where you dumped it all, and see what you've already got. See what you can get out of storage and put it in place. You don't stop being competent at doing this if you're doing it in practice. You might be slower. I have to say my IV drug administration is somewhat slower than most people's these days. That's not because I can't do it, it's just that I don't do it as frequently as I used to, and so I'm much slower, but that doesn't stop you being competent. So the next performer we've got is something called a mini KEX, and that's short for mini clinical examination, i.e. you're not going to spend hours going through this, you're just going to do it a bit at a time. And we do expect several of these. So what would happen here is you would be examined, i.e. assessed, doing something. So minimum of 3 adults and 3 older people. Again, at least 1 patient from each decade, so teens, 20s, 30s, 40s, 50s. The primary complaint has to be on at least 5 different body systems. So again, this is to stop you doing 5 MIs, 5 sepsis, 5 strokes. It's to make sure you get a bit of variety and can show your flexibility and adaptability. And it needs to be accompanied by a verified annotated record of the case. So you just take a copy of patient's notes, make sure they're anonymized, you annotate that and attach it to the clinical examination record. You also need to have an initial assessment and prioritisation mini KEX in there for adults and older adults, and that's not too difficult to do. That's simply someone assessing you in triage when you're at that point of talk to triage and getting competent at it. We'll need to include at least 1 episode of care where the patient required resuscitation, at least 1 where it was new acute complaint, so pneumonia, let's say, for the sake of argument, an episode of care where it's acute on chronic, so exacerbation of COPD, and an episode of care for someone with a cognitive impairment. So that could be someone who's delirious. It could be someone who's got a learning disability, an acquired brain injury. It could be someone with dementia. It could be a patient who has a mental health problem and is psychotic. So there's quite a lot of options there. And an episode of care where the patient is going to require emergency surgery. So that might be a AAA, it might be a bowel obstruction, it might be multi-oral trauma. It doesn't matter. What matters is that the patient needs emergency surgery, and you're going to have to demonstrate in there somewhere that you've prepped them for emergency surgery. Everyone all right so far with that? Silence. Okay. So next one is multi-source feedback. Now again, we've got performers for all these things that will be available on the website, so you can choose to use that, and that will make collection easier because everybody will be on the same sort of paperwork. Now, what would you be thinking in terms of multi-source feedback? Who do you think you could ask for feedback on your performance? There's not enough of us to worry too much about the chat, so feel free to come off mute and just shout out.
A patient.
Well, you can, Ros, but it's generally considered ethically unsound to ask a patient. So you're not supposed to solicit. But if a patient voluntarily gives you feedback, well done, because they don't do it very often in A&E.
No.
But if you get something nice from a patient or a relative, then absolutely you can include it in your feedback. But for goodness sake, make sure it's anonymised so that we couldn't track the patient down. Those sort of things tend to be, you did a fabulous job after my husband, wife, when they died, thank you very much. But then they often add the name of the deceased and what have you. So that can, you just got to watch that. So you make sure it's blanked out. Or you just get, thank you for looking after Billy when he was dying, you know.
I think it's worth having it verified though, so that you've got your assessor
Absolutely.
sees the original, so that you can see that it's an original piece of work. And the other thing I used to do as a consultant nurse, when I used to see patients coming back to clinic, I used to ask how they felt the care they'd had in the last episode, and was able to give verbal feedback to the individuals from that. So that's something that the more senior people could take on board, is maybe to ask how do they feel that the care that they had was, when it comes to getting patient feedback.
Yeah, I do a lot of mortality reviews, and I do a lot of safeguarding referral reviews and things. So if we have a really good example of a referral, or I come across something really good in notes when I'm doing a review, then I'll email the member of staff concerned and just say, you did an absolutely fantastic job. That's made that mortality review really easy to do, or that complaint review really easy to do, because your documentation was so thorough. So what we've said is that we need something from your line manager or a clinical supervisor, someone who's working alongside you. We need 3 bits of feedback from nursing colleagues. And it doesn't matter what level that is, although it'd probably be wise to get it across the levels. We need 3 bits of feedback from multi-professional team members, a doctor, a physio, an OT, someone like that. And we need 2 from other staff, receptionists, domestic supporters. That's deliberate, and there is a form for them, so it's all right. They don't have to kind of make it up and say, Ross is the most wonderful nurse I've ever worked with. She's fabulous, which is very lovely to receive, but actually it's not terribly specific and helpful and demonstrative that you've done anything other than slip them a chocolate bar. So it's quite helpful to have the form and get that filled out. In addition, you need 2 succinct, and I mean succinct, don't drag it out to 3,000 words, succinct analytical reflective accounts of your own emotional resilience management. Now, we all know that it's very, very stressful working in A&E at times. Our department had 120 patients in the other day. I don't know how yours is bearing up, Ros, but 120 was
We've had an awful week. Awful.
And it's just, thank God for COVID in a way, because if it wasn't for COVID, that would be double that, because everybody has at least one supporter usually. So that would have been 240 bodies to dodge around. It's been 120 bodies because of COVID and nobody being allowed a supporter unless they need a carer with them. So maybe we've had about 130 bodies tops. That makes it a lot less stressful. I should add that's adults only in that 120. But that causes emotional resilience issues. So it's just looking at yourself and how you manage your stress and how that's evolved really as you've got used to A&E. And then a reflective account of supporting a junior colleague and role modelling, which can be quite stressful as well. Trying to act when you've got the frock on, so to speak. And then your personal development plan and evaluation of progress. Certainly all my staff have a personal development plan, and I would expect to see that that was evaluated as they go along. I've just found an arrow at the bottom. I'm going to try that. Haha, that works. Right, now, quite a big bit of evidence required is anatomy and physiology. Now, you've got to demonstrate you know it, and you've got to demonstrate your knowledge. So that's quite interesting. Lots of different ways you can do that. So you might want to include it in your 6 analytical reflections. It certainly helps to kind of go, right, well, this is how this bit of the body works, and this is how it went wrong on this occasion, and this is what I did to try and retrieve it, and this is how I noticed it. You could do annotated diagrams of body systems. Your assessor will be deeply unimpressed if you do a primary school level diagram of the GI system that says, here's the esophagus, here's the stomach, here's the duodenum, here's the gallbladder. You know, it does need to be considerably more detailed than that. It's no good thinking you'll get away with that. Some people do spider diagrams. I've seen the most phenomenal spider diagrams that go, what do I know about the lungs? And off they go, writing lots of bits in spider diagrams, and they can be quite fabulous. Or you could do, what do you know about the body, and do your entire anatomy and physiology as one big spider diagram. Or you might be the sort that likes doing MCQs online. That'd be okay, because it would demonstrate your ability to know it. I would just caution you that those can be very bulky when it comes to putting them in a folder, and we really, really, really don't need to see the entirety of every single slide from an online A&P course. I've seen a whole lever arch file dedicated to MCQs, and I felt like failing the person just because there was too much information.
I think we need to take some advice on that, because I know that the Agorad Centre are not so keen on MCQs.
No, I'd be inclined to agree with them on that.
Yeah, I think the importance is, if you've done a test, that you write down what the objectives were, what you covered, and if you're making records as you're going along on your MCQ of your rationale for why you chose A over B or B over C, then those are the things that will demonstrate you with critical thinking that would go into your portfolio, rather than the MCQ and just choosing it.
It's not the best option, and does need some thought. No. My preferred option is an anatomy table, but that's just the way my brain works. So other people will be much happier with pictures and spider diagrams, but my brain works slightly differently, and I like an anatomy table. So I'll show you what I mean by that in a minute. Never mind what I've written there, because I'll explain it as I go. So here's an example of what I mean by an anatomy table. You put together something that lists every body system down one column, and then you put how it functions in an adult. So that's what the textbook says usually. How that varies in an older adult, and how that varies in a developing child. And then you could add, or not, up to you, a column that says what life-threatening conditions affect that system. So with respiratory, you might want to say what the normal adult rest rate is, and the normal SATs and the normal tidal volume, and the way it works in that you need the intercostal muscles working and the diaphragm, and an intact brain to make sure that your brain instructs your respiratory system to do its thing. The variance on the older adult might be around you've done some damage with smoking, you've maybe got some blood clots, you've got a reduced amount of elasticity, you've got a thinner chest wall, but you might have a larger abdomen because you've put on a lot of weight as you got older, and so you've got a little bit of diaphragmatic splinting. With a developing child, you might be talking about the fact that they're more dependent on the diaphragm to breathe and less dependent on the intercostal muscles, because in small children intercostal muscles are underdeveloped. And then in the life-threatening conditions column, you might be talking about pneumothorax, hemopneumothorax, massive PE, that sort of thing. So nobody's expecting you to download everything from a textbook. It's about paraphrasing and editing so that you've got it nice and succinctly. But if you were doing the adult and older adult unit, you would need to demonstrate at least those 2 columns. If you were doing a child and young person unit in addition, well, save yourself redoing the whole thing and just add a 3rd column, and then you can demonstrate that. And all the lectures we're going to be doing in the AFEN programme will cover the whole age range, so don't worry that you're going to suddenly find that you've not been taught it over the course of the AFEN programme. We will be covering the whole age range, so you should be able to do that way. Emma, were you wanting to ask a question, or were you just adjusting your screen? I can see, I'm lip reading, you're going adjusting your screen. That's fair enough. Okay, so that's another way of doing it, and it's quite interesting trying to prove anatomy and physiology. Right. Oh, guess what? It's time for a break. I've rushed through that lot. Because there's so few of us, I've rushed through, and entirely up to you. If you're ready for a break, we'll take a break, or I'll just press on to the end. I'll take a poll on that, because at the speed we're going, I think we could probably finish well inside the time. What do people want to do? So you're all being quiet. If I'd had 30 people, it would have taken me a lot longer to get there, because the contributions would have flown in.
I don't mind.
Right, okay.
Happy to continue.
Okay.
Happy to continue. Right, let's do that then. Let's go for finish earlier rather than break far too early. Okay. So I think that's all very well saying all of that. And you know, you're kind of sitting there thinking, oh, that's quite a lot of work. Yes, it is. But remember, we don't want it tomorrow. And you just build it up gradually as you do things. And you'd be expecting to get some teaching from work and from the lectures online. So it's not that this has to be all achieved overnight. It doesn't. So other things that you need to think about is what's your assessor looking for? So it's really important. Now, Judith will be teaching the assessors later next week, but it's good from a participant, a learner point of view to understand what your assessor is looking for. So your assessor is looking to make sure that your evidence meets all of the learning criteria and the learning outcomes and the assessment criteria. So when you sign up, there are learning outcomes for each unit of the qualification. And you need to go through those and check which learning outcomes and assessment criteria your individual bit of evidence covers. So for example, let's say we're going to do an analytical reflection, and we're going to do it on, let's keep it simple, an older adult with sepsis. So what learning outcomes could we cover by that reflection? Maybe just write the reflection and see what you come up with, but actually probably better to read the learning outcomes first and see if you can then aim to cover them as you write the reflection. And actually, if you try to target your work to the outcomes, you'll find that you get there quicker with less effort, really. So if you know that you're going to have to talk about somebody who has potentially got a reduced cognition, then you might want to talk in your reflection about reduced cognition and recognizing that, understanding it's there. You might want, and testing it. You might want to talk about the fact that there was an underlying reduced cognition and that's being compounded by sepsis. Or you might want to do it the other way around and say that this patient came in unwell and their presenting complaint was unwell, and you had to work your way through because this person had slightly deranged observations. You made some sort of judgment about how frequently you should do those observations and what you base that on. And then you worked your way through and noticed that there was the impaired cognition, so you processed that. And then you thought, hang on a minute, this is starting to look like it might be something related to their brain. So what would that be? Could this be a delirium on top of their cognitive impairment, and so on and so forth? So you build it up, and as you do that, you've knocked out learning outcomes about recognizing a deteriorating patient, picking up on impaired cognition. You've probably got a person in their 70s or 80s, so that's that decade sorted. You're heading for sepsis, so that sorts out your elderly person with sepsis. And then you might find that you have to give a load of IV medication, you have to give oxygen, etc., etc. So as you work your way through the list of outcomes, you'll be able to see how that reflection on that one case can cover an awful lot of learning outcomes. Now, you will also need to keep track of everything, a standardized index. We'll provide some examples, and I'm not going to do that tonight, but we'll provide you an index example so that you can see what we mean. And it's simply a case of having all the assessment criteria listed and then saying which piece of evidence demonstrates that you've covered that assessment criterion, and where I can find that in your portfolio. If I'm your assessor or I'm on the IQA, the Internal Quality Assurance Panel, then I don't want to be faffing about spending hours and hours and hours trying to find where you've hidden it. Label it really clearly for me. Make sure that if that bit about recognizing impaired cognition is in analytical case 1, then you put analytical case 1 and you give me a red sticker or whatever on your thing, or however you want to label it electronically, so that I can easily and quickly go straight to that, read it and go, yeah, do you know what? This learner has provided that evidence, and I can see that they've provided it. And lo and behold, attached to it is a verified set of anonymized notes that proves that this person did look after that patient. For your written work, you need to have referenced it, and we're going to ask you to use the Harvard referencing format, please. That's what
I come in there, Jeanette.
Yes.
I disagree with the just saying 1, because if you were doing an annotated record, then it's far easier to use a numbered system for spacing.
That would be for an annotated record. It wouldn't be for an analytical reflection, would it, Judith?
No, not for an analytical reflection.
No, because when you're doing a reflection, you would normally do it fairly academic style. I agree with you that when you're doing an annotated record, which is slightly different, or a spider diagram, then you would want to use 1s and 2s and 3s everywhere, because trying to get that listed off by surname and date will be a problem. So you need to mix and match a little bit, but be aware that if you're going to produce a written piece of work, then it needs to be thought through and properly referenced. I would suggest you look at FEN assessment performers to make sure you've got all the necessary information. Now, the reason that's an issue is there are lots of things you and your assessor may not think of. And if you haven't thought of them, you won't capture them. We'd like to think that we or a GORAD have thought of them already and we're slightly ahead of you. And so by using the performers, it will prompt you to look at certain things, or prompt your assessor when they're doing a mini clinical examination with you to have a look at certain aspects. Can anyone think of times before where they've gone through, sailed through something thinking that was fine, and then their assessor said, oh yes, but you didn't think of, or you didn't do X, Y, or Z? Is that something anyone's come across before? No? Oh, well, you're all very good at that then. So that's just a reminder in that case. Okay, so the next assessment principle is that all the assessments have to produce outcomes that are authentic. That means all the work is your own. So that's what your assessor's looking for. They're looking to see that all of the work in your portfolio is yours. So how do we do that? Firstly, you work closely with your clinical supervisors and your assessor to make sure that when they verify something, they know it's yours, and to make sure that you've picked cases sensibly. Other thing that's important is if you're going to give us other people's handwriting with their names on, and I'm thinking of your multi-source feedback here, or your verification, then you will need to have a permission form from the people whose names you've used, so that you can display that name and signature in your portfolio. So again, make a list. We can put up some examples on the website just to show how you would do that, how you could put a form up, and then it's a one-off. You get everybody to sign that as you, oh, what have I touched? That was distressing. Oops, there we go. No, back. Goodness me, it's very sensitive, this. So you do that as a one-off, and you've then got a permission sheet in your portfolio that says, I, Jeanette Welsh, am happy for my name and signature to appear in Judith Morgan's portfolio. It's worth using a plagiarism checker. There's nothing more upsetting when you're marking work than having to return it to the learner because they've plagiarized. It's very, very unpleasant and very, very difficult, but you cannot quote other people's work at length without acknowledging them and without putting everything in quote marks. And you can't quote other people at length full stop. You have to paraphrase their work. It's no good saying Judith Morgan in 1995 said, and then copying out 4 paragraphs of something that Judith published in a journal. You need to summarize and paraphrase. Other things that's important about authenticity is your assessor someone who understands emergency nursing and the current practices and the evidence-based practice and the research. So it would be important that your assessor can do all that. And from a departmental point of view, if you're picking assessors, then it's important that assessors are picked for their ability to cover that item. And I've already said, please, please, please paraphrase or use your own words. When you're reading people's reflective accounts or anything of that nature, case reviews, case studies, it's so obvious when they start using somebody else's words, when they take a sentence or a paragraph out of somebody else's work and put it into theirs. And the thing that's obvious about it is that the tone changes and the style and the choice of words. And so most of the way through, you get a feel for the character of the person who's writing, and you get a feel for what they understand. And when you suddenly find that there's a big leap in that level of language, you know that that's not theirs, and you know that they've taken out somewhere else, and you know you're going to have to return that work and ask them to do it again. And honestly, that's quite heartbreaking as an assessor. So just avoid it in the first place. Don't plagiarise. Don't cut out other people's work. Always, always, always summarise and paraphrase. Are we all okay with that? Oh, I'm very quiet. You're all just taking notes and going, yes, that's fine. That's what we thought, Jeanette. Okay, so the next thing your assessor is looking for is not just your assessor, actually. The other thing that Agorid are looking for when we're looking at producing work for qualification is that the assessment has to be reliable. So the evidence has to be consistent and generate outcomes that would be replicated if we did the same assessment elsewhere. So if I did a practical assessment with you for a demonstration of practice, for example, and you plastered a patient's leg and I assessed your ability to plaster, then what's really helpful is if I tipped up in somebody else's department and I did exactly that same assessment on another candidate, then that assessment would be consistent between the two departments and between the two assessors. Now, I'm not suggesting that we have assessors running around the country assessing people. That's silly. But it's one reason why we would use the FEN assessment performers, because then it's going to come out more or less the same. So if we, obviously the mini-KEX performance and the demonstration of practice performance are not so specific that they say this person's done an above elbow plaster and this is what they must do. But it's important to go through the same sort of steps and make sure that people are consistently delivering good practice. Your assessor is going to have standard documents that they have to check your written evidence against. So your case reviews and your annotated notes your assessor will have documents that they go through that will say, you must look for this and common mistakes are this. So they'll be looking through, making sure that everything you're supposed to have done has been covered. Now, there is an opportunity to do a different site partnership group. So there's an opportunity where departments are close together for assessors to cooperate and look at unassessed learner evidence and assessed learner evidence. So they can do that if they want, but that won't work everywhere just because departments are a long distance apart, but that's an option. So that's another way that assessors can check that evidence is reliable and that the evidence their learners are producing is as robust as the evidence that other people's learners are providing. And your assessor will have to forward one type of evidence to an internal quality assessor for review and feedback. So that's after they've marked it, it'll have to go to an internal quality assessor. And then overall, the FEN Internal Quality Assurance Board will review your assessor's work and make sure that your assessor isn't being any meaner or any more generous than any other assessor. Now, this is similar to a university system, similar but different. In universities, what happens is that your work gets first marked, usually by your tutor, and then some or all of it, depending on the number in your cohort and the exact university procedures, will be marked by a second marker. And then a proportion of those, once they've agreed the marks between the two of them, a proportion of those have to be sent to an external examiner who doesn't work at that university at all, for that external examiner to say, right, those are, usually they take it as one from each grade at universities, and they will take it that I want to see the difference in the work, and all fails and all top grades have to go to external examiners to be absolutely sure that internal markers are being fair. So that's exactly the same sort of system with FEN, that there's an internal quality assurance board effectively behaving like the external examiner. And that's for your reassurance that it's not just your assessor being mean to you.
And if there's an external quality assurance person as well,
On the top of that.
On top of that, who Agorid appoint. and they
Even better.
will look at the work of the Internal Quality Assurance Board.
So the point of that, folks, is that nobody gets to just be an outlier and be really mean to you or to be really overgenerous. Your friend doesn't get to mark you as brilliant just because they're your friend. It's all cross-checked or moderated. That's another word that often gets used. Okay. So the next thing that's important and that your assessor will be looking for is that all your assessments have to produce current outcomes. So what we're looking for is that your evidence is up to date and referenced. Ideally, it would be within the last 3 years, but you will need some that have been done in the last year prior to submission. So important things to make sure that one gets a big tick in the box is, oops, what happened there? I'm missing I'm missing a line compared to my copy here. The first line on my copy, but it's not on this slide, is all your evidence dated? Have you got the date on it? It sounds very basic, but it's really, really important that we have the date on it. Does your evidence fit with current practice? The people who are marking it know what current practice is. So if you're out of date, it will show. It doesn't matter if the example you're using is out of date. Say, for example, you want to show something that was a year or two ago and practice has changed since then, because what you can do is then reflect on what you used to do and compare it to what you do now. So a nice straightforward example of that would be around MIs. When we moved from thrombolizing in the department to sending them to the cath lab rather and not stopping off. So if you had an old case, you could dig that up and use that as the basis of a new analytical reflection and compare it to a current practice and say, look at the difference there and look at the similarities. So there's several bits that are the same, but actually overall, I'm not going to go sticking drugs into this person. I don't have to make drug calculations at speed for this person. I simply have to get informed consent and get them off down to the cath lab. Or I have to transport them to the cath lab, and therein lies some interesting ethical discussion. If you're when you're referencing, that should be in the last 5 years, unless it's a seminal work. I'm not going to ask you, and neither is any other assessor going to ask you to try and suggest that Maslow wasn't a seminal work. He absolutely was. And so Maslow can be quoted because his work is absolutely, I beg pardon, that of mine is the phone, but someone in the house will answer it. And other things that would be important is that your assessor's reviewing your portfolio on a regular basis. So long as your assessor's regularly seeing your progress, then there's a reasonable chance that everything will be current and up to date. Everybody happy with that? Mm-hmm. You're all being very quiet.
The other reason that you want your assessor to review your portfolio regularly is if they come across, and I've experienced it myself, where you see the portfolio and it's a couple of months down the line and you realise they're making the same mistake over and over again. So if you take your portfolio regularly to your assessor or somebody who's going to say that that is good evidence, then at an early stage, they can then input and say, actually, you need to take this a bit deeper, or you haven't got sufficient critical thinking in there, or can give you some tips on how to do it in a slightly more effective way that will get you bigger marks.
Mm. Whilst Judith mentions the analytical bit, that's really, really important. One thing I learnt early on when getting my staff to do portfolios was that the consistent problem was lack of analysis. For those of you who are more education minded, and I know some of you are, then I think it might help to have Bloom's taxonomy in your head, that you've got to have knowledge, understanding, application, and then analysis. It's no good having just knowledge or just understanding of just application. You've got to demonstrate all of it. So it's important that you can say, yes, I know this. Yes, I understand this. And here's how I understand it, because I've summarized it and I've paraphrased it. And I can apply it because here's how I've applied my abilities to this old person with sepsis. Here's how I've applied them to this 34-year-old with an acquired brain injury. Here's how I've applied it to a 56-year-old with compound tib fib that has no cognitive impairment, but half a dozen children attached that I've got to sort out as well. So you need to show that application, but then the analysis is, did that work? Is it good enough? Does that evidence that people are saying I should be using actually match up to my practice? When I go and have a look at the evidence base, is all the evidence lining up in the same line, or are there lots of divergent opinions? Now, at the moment, of course, with COVID, we've seen lots and lots of divergent opinions, and it's thrown people a bit, because what you've seen is scientists disagreeing with each other, and the papers don't all say the same thing. They don't all come to the same conclusions. And that's because it's something very new, and we're not seeing exactly the same experience. And we're seeing people trying out different theories and trying out different treatments and trying out this, that, and the other. And so the evidence base hasn't yet formed. And that's quite destabilizing for a lot of people, seeing that actually worked out in practice. But for other things that are more well established, then we do see that there is a certain amount of coalescence around theory and coalescence around what's acceptable. And so you would expect to see some discussion of that in the title says it all really, in analytical reflections. Okay, so your assessor is also looking for outcomes that are sufficient. It's no good thinking that if you give me a demonstration of practice that you are competent in all those skills that I put up earlier, that's going to be sufficient to get you through a whole unit. It's absolutely not. So we have to show that enough work has been done to justify the credit. There's credit value attached to all of the qualification units, and though that credit value is attached to how much work you have to put in, it equates to a certain number of hours work. Now, some of those hours will be on webinars. So if you were to attend all of the webinars, that's 46 in a year, double that, that's 92 hours. So 92 hours worth of work is worth a certain amount of credits, but then you've also got to put in some research time where you've got to go through library stuff, do searches on the internet, read up things. You've also got to watch or read extra resources that your lecturer has suggested. You might need to go and do something in your department. You might need to go and do your resuscitation course. You might need to have something tested. You might need to be taught a new skill. And then you've actually got to do the written work, and that takes time too. So all of those hours we have worked out and put a value against, and it's when you work out how many hours work it will take that you get a credit value for the unit. And so we have a very clear idea about how much work that is. And so the work in the portfolio has got to justify the amount of credit you're getting for it, and it has to enable a consistent and reliable judgment. Is the phrase that's used. And so what we're looking for is that in your evidence, you've shown you've got an in-depth knowledge and understanding of the unit and the evidence required. So what does that mean? It means that if you tell me about your old person with sepsis, actually you can give me chapter and verse on sepsis, that you absolutely understand where it might have arisen in the body, how it might have arisen, how it then spread, how it became sepsis. What is the difference between a local infection and sepsis? How come a chest infection is a chest infection, but you might have sepsis of chest origin? How does that work? How did somebody get to the point of suggesting the sepsis 6? what evidence is there for that sepsis 6? What evidence is there that you give 3 and you take 3? What are they showing you? And in your patient, how does that come across? How did you recognize that sepsis? What made you think that it was sepsis in the first place? Or how did you narrow it down to that from other possible things that could be going on? How did you persuade a delirious combative patient that it would be a really good idea to give the oxygen via the nose and mouth and not the forehead? And so on and so forth. So you're showing us that you really, really understand this subject. And you all know that a nurse in their first few weeks working in an A&E department can't do that. You all know that. And you all know that it takes probably 2 years of working in A&E to be able to do that across anything that can come in the door. So you might really click into sepsis quite quickly. You might get the hang of MIs quite quickly, but building up that repertoire across all the body systems, across all the conditions that can occur to those body systems is, it takes time, and you need to see that being inculcated and really part of you. What I love seeing, absolutely love seeing, is learners who say, but we've always done it that way. I've always known that. It's common sense. And it isn't common sense, because it's hard-won knowledge. They have acquired that knowledge. They've acquired that skill, and it's taken them years to do it. It's not just the years they've spent in A&E. It's the years they spent learning to be nurses in the first place and picking up subtle signs. It's not something that just anyone can do in a moment. It's a really highly skilled thing, and pushing that across and showing it and showing your development from knowing very little to really getting it it's a lovely thing to see. So sufficient evidence. So here's second point. Here's where your index is really helpful, because as you go through the index and you look at all the learning outcomes and all the assessment criteria, have you listed evidence against each one of those? You have to have covered each one off, and the more pieces of evidence that cover all of your learning outcomes, the better. Very carefully written annotated records and case reviews can cover so many learning outcomes. It's really possible to achieve with a bit of thought and a bit of consideration of your outcomes before you start writing. You can really, really achieve an awful lot against all of the criteria with not that many pieces of evidence.
And can I say, Jeanette, add there
Yes.
that they can go across units as well?
Oh, absolutely.
So if you've got a piece of evidence for you that you've written up as an annotated note for, and you're working towards your adult and older person unit, the information there could also go towards the cause, and could probably go towards the trauma one if there's a trauma stuff. It might even fit with the psychological care, so it can go across all of them, the same piece of evidence. So you can use the same piece of evidence time and time again. So that's why knowing the document really well will make it that much easier for you to develop and write your competence. The evidence for your competence.
That's a really important point, because so many people get bogged down thinking they've got to provide separate pieces of evidence for every single competence, and that's what makes people feel defeated and dragged down. And you mustn't feel defeated and dragged down, because so many competencies can be evidenced in actually very small numbers of cases. You just have to be very sensible about how you write your case and how you choose your case, so that it shows as many outcomes as possible. And certainly, as I said when we were talking about anatomy tables, if you think that there's a possibility you might do the child module, then do your anatomy table with all the variances in straight away. Add the life-threatening stuff, and then it's all there and it's all ready. And actually, for all of the competencies, for those things, you're simply saying, please see anatomy and physiology table or spider diagram or whatever it is. Your assessor will be looking to see that each element of evidence required has been delivered in full. So I went through with you at the beginning a list of what we're looking for. So they will want to see that you have indeed got 6 focused analytical reflections. Well, that's easy. You simply make sure that they're all in the same section together so that your assessor can see that there are 6 cases. You've got to provide 10 mini clinical examinations, the mini KEX assessments. Well, that's easy too. Put those in a section together and number them. You've got to have some demonstration of procedural skills. So that's fine. You put them in a section and you number them all so that you've color coded or flagged or numbered, however you want to do it. Doesn't really matter so long as your internal navigation system works. So it's all there and really obvious to see. And then your multi-source feedback, that's in another section and it's clearly labelled as feedback from manager, feedback from nursing colleague, feedback from medical colleague, feedback from reception colleague. So it's really, really easy to see that each element of that evidence has been delivered in full. And that covers the all the preset pieces of evidence as well. And I've said already, but I'm going to repeat it again because it's worth repeating, that if you work closely with your assessor, they'll keep you on track and they'll make sure that you don't fail to analyse and that you don't end up with a bit of a storybook. If you have case reviews that are he said, she said, then the doctor did, and then the relative said, then that's not telling us anything about your in-depth knowledge and understanding. It's only a narrative of what happened from your perspective. And you do need to work with a clinical supervisor to agree how much coverage you need. And don't worry about them having different opinions because we'll be training the assessors as well, so they'll all be getting a consistent message from Judith about what they should be looking for when they are assessing, and that will match up with what I'm telling you about what you need to provide to make sure that that box is ticked for them. That all okay with everybody? Yeah. Everybody's just nodding at me quietly. Yes, all right, Jeanette, I've got it. Okay. Right, now the next criteria is that evidence has to be comparable. So that means that all your assessment evidence is comparable in a standard between assessments, both within a unit that you're doing and between learners at the same level. So a lot of that is about us putting things in place to make sure that's the case so that your assessor has a relatively easy time of it. Again, really, really easy ways of doing that. Use the performers for practical assessments. So that's the mini KEX and the DOPS forms, because then you're all working on the same forms and the comparable thing is really obvious when we're looking at it from a quality assessment point of view. Use the unit index to facilitate sign-off because it's all there, and then you can just make sure that the evidence is all listed off and your assessor can have an easy sign-off time. Your assessor will have to send samples work off for consistency checking. So that's partly to make sure that the issue of assessments between your place of work and another place of work is comparable. And it's also about, is this work for the psychological unit comparable with someone else in a slightly different setup? Can we achieve comparability between those pieces of evidence? Let's just say, for the sake of argument, we did an analytical case review on a patient who'd taken an overdose, and could we show that that evidence was comparable, looking for the same sort of things in Letterkenny, where Caroline is, and Emma, I've forgotten which hospital you're in, but you're in South Wales. So is that comparable? Are they doing reasonably similar stuff to a reasonably similar level? Your assessor is allowed to ask for a second opinion from an internal quality assurer if they're not sure whether the evidence is adequate, or they're not sure whether that evidence is the right standard, or whether they think, well, hang on a bit, nobody else has asked to provide evidence this way. I don't know, perhaps by an audio file or something. So your assessor is perfectly at liberty to ask for a second opinion if they're unsure. And that shouldn't be taken as a bad thing. That's a good thing, because they're checking that they're not doing something or not agreeing to something that will mean that you don't pass. Equally, if you're concerned that your assessor hasn't been fair to you, you can submit it to an internal quality assurer for review. But you're again at liberty to do that to make sure that's to your satisfaction as well, and that you have the chance to appeal, so to speak. Are we all happy with that one? Yes, Jeanette, nods some heads. Okay, good. Right, nearly there. The next thing that your assessor is looking for is that the assessment places reasonable demands on you. Now, we don't want anybody burnt out and stressed beyond bearing because they think they've got all this enormous amount of work to do and they'll never get it done. Firstly, pace yourself. Nobody expects you to do it without being taught. Nobody expects you to do it without practice, and nobody expects you to do it all at once. It's a marathon, it's not a sprint. So just take it steadily. There is no absolute time limit on this, although clearly you don't want it to be dragging on for 10 years or even 5, but there's no time limit. FEN have gone to, the FEN board have gone to a lot of trouble to make sure that all the units have really clear learning outcomes that are completely unambiguous, and that we've got assessment criteria identified for your assessors. It's taken many, many hours of work and many revisions by lots and lots of different people. So we think now that we've got it about as clear as we're ever going to get it. So it should be manageable. It should be achievable in reasonable size chunks. And you will see that the number of credits on each unit is not necessarily absolutely the same. Judith, you'll need to remind me, but I think the adult and older adult is 40, is it 40 credits or 60? Is she gone? She's given up on me.
On mute.
Oh, you're looking at her.
Sorry.
You're on mute.
Yes.
It's all right.
The credits for the age-related units are 60, and for all the other units, look as if they're going to be 20.
Right, thank you. That's what I thought it was. So what that means is that if you've got a 60 credit unit, you would expect it to take you 3 times longer to achieve than a 20 credit unit. Okay, and I can, obviously you're going to have to put in an awful lot of effort with the adult and older adult unit. We completely understand that, but that's the bread and butter work. What we've also done, just for those of you who are going to be in a position where your work unit asks you to do both adult and child, because there's an awful lot of crossover in the teaching and in the work required, we are offering those of you who work in mixed units the opportunity to do a condensed child unit, which will be 20 credits, so you don't have to put in the same amount of effort twice. You put in that effort once and then you extend it to cover child. And then those people who work it just in child units do the full 60 credit child unit. So you would expect to spend many hours on adults and older adults. You'd expect to spend less on the psychological unit, and you'd expect to spend less time on minor injuries or trauma or others. Have a look at the unit requirements for the different things. I gave you as an example on this presentation the requirements for the adult and older adult unit. But if I just have a look quickly at the minor trauma unit, then for that, you don't need quite so much. For that, you're going to need mini-KEX assessments with an annotated patient record for 3 separate things. And then you're going to need demonstrations of practice, assessments with annotated patient records for, can't count the number there quickly, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, for 12 things. So that is a much smaller amount of evidence that you're going to need and not quite so worrisome. If you're looking at the psychological unit, then you're going to need, for that, you're going to have to do 4 mini-KEX, and you're going to have to do a reflection on caring for a patient with a psychological need. So you can see that those things are not quite as onerous and quite as long as the adult and older adult unit, and that's because there is more to be covered and there are more credits attached to the age-related units. Again, I've said it several times, but this is important, and it's important for fairness and consistency, that if you use the proformas, then it standardizes what is expected of you. We don't then run into assessors or managers that are very exacting in their standards and expect some much higher standard of you than would be expected of junior nurses elsewhere. So we're looking for manageable expectations, not expecting you to be as expert as a consultant nurse or an ANP when you've only had 2 years in A&E. And there is again the option of a different site partnership where units are sufficiently close enough together to do it, to have a look at unassessed learners' evidence between the assessors and look at assessed evidence, just to make sure that there's no unreasonable demands being made, and provide feedback for the assessor. And that would be in quite a collegial fashion. I've sat on many a QA panel of different sorts where people go, you're a bit harsh there, or I think you better, you know, or that's a bit generous, I'm not sure I'd do that. And so they're not conflict situations. They're respectful and adult, and discussing what's reasonable, what's not reasonable, is that manageable, is that too big, while we sort it out. And we
I
come
think
to
it's a supportive
conclusion.
environment.
Absolutely supportive. You wouldn't, it's not about criticizing people. It's about saying, it's a bit weak in that area. If I was you, I'd advise them to strengthen that aspect a bit. And then finally, all assessments have to produce outcomes that are fair and minimize bias. The one thing we all seem to recognize without fail from a very, very early age is fairness. And we don't really need to be told about this. We're all quite good at it. Small children go, but that's not fair. And usually they're right. And life isn't fair always, but assessment should be. And so assessment needs to be seen to be fair, and it shouldn't be discriminatory in any way or biased towards older people or younger people or men or women or whatever. Again, you're going to be bored about this statement, but again, if you use the proformas for practical assessments and your assessor uses the proformas for assessing written work, then that takes out bias and ensures fairness, because then everybody's looking for the same things. Now, you could also say it takes out the spark of interest, but the spark of interest will come through anyway. We just need to make sure that people don't treat anyone unfairly. Again, using the index unit will help. Try that one the other way around. The unit index will help sign off and provide consistency, because then we can see if people are going overboard in one place or another and producing far too much evidence, far more than they needed, or perhaps not enough evidence in another place. All the comments made by assessors are reviewed at the Internal Quality Assurance Board, and so that's important too, so that your assessor's comments are seen to be constructive and helpful in your development, rather than being derogatory in any way or highly critical and making you feel like you can't do it. We want you to feel like you can do it, we want you to pass, and we want you to do well and do well for your patients. If you raise concerns as a learner, then you can submit your work to the Internal Quality Assurer for review. So I said that earlier, if you want to appeal, that's effectively your appeals procedure. If you disagree with your assessor, you go to the Internal Quality Assurer. And then the Internal Quality Assurance Board reviews the work of all the assessors and will pick up any issues about individual assessors or about an assessment, or about the quality of evidence, or perhaps, as Judith mentioned, and I've certainly seen, the issues that arise frequently in assessment. So I've definitely noticed issues with plagiarism and just quoting quoting people without attributing it and without summarising, paraphrasing. I've also recognised, as has Judith, the lack of analysis and the lack of application of evidence to practice. So those sorts of things come up as consistent themes when you look at things from an assurance board point of view. And that, folks, is the evidence you need to start building up to put into a portfolio and what your assessor will be looking for.
Can I come in with a couple of things
Any
there,
questions?
Jeanette?
Please do.
The one thing that I've seen happen at the Internal Quality Assurance Board is that the work of an assessor was thought to be not stringent enough. Now, it's a reflection on the assessor, not on the learner. But what it means is that the learner has to produce more evidence. But within this way of working and being assessed, there is no such thing as failure. It's just that you haven't provided sufficient evidence to get you across the line as yet. So there's no failure within this model. It's about you continuing to work on it until you've achieved the level that you need to have that sign off. So there's no, like the universities where you have 2 chances of submission, and if you fail on the second one, that's it, you're off the course and you've lost everything. That isn't the case with this way forward. Yeah. And the other thing I would like to add is that I know we said what the minimum number of mini KECs are, but they're a fantastic way of getting evidence very, very quickly to show exactly what you're doing in practice and to get a lot of your competencies signed off, especially when you add it with probably an annotated record and a copy of your own records. Thanks, Jeanette.
You're welcome. Does anyone else have any questions or comments they'd like to make at this point? No, Rasheen's shaking her head.
If a student
Roz.
wants to email in a question, or how do they do that?
Email a question to whom?
To any of us.
Would that be when they're on a webinar or when they're working on their portfolio?
Working on their portfolio.
If they're working on their portfolio, I'd be expecting them to work with their clinical supervisor or assessor in their place of work.
Right, so, not to
I would expect them to work with their assessor at work. I don't really mean it like a student has a mentor at work, but you know, the doctors have educational supervisors, and so think of it in that sort of way, that you'd expect there to be 1 or 2 assessors at work who can do the mini KECs with them, stand there and mark them off. You'd expect that most clinical supervisors of sufficient seniority would be signing them off for the demonstration of practice issues that, you know, they can put on a plaster or they can do venipuncture cannulation. So you'd expect that normal system of signing people off because they're now competent at would be what you'd use first. And it's only if you run into a problem with that you'd expect anyone to then raise an issue outside the immediate.
It might be a question they might ask.
Yes, so it's worth you knowing the answer now.
Yeah.
So I would expect the assessor, and then if the assessor can't answer the question, that's fine. The assessor comes to the Quality Assurance Board and says, I've got this problem, how do I answer it?
Yeah.
And then they get their answer. So assessors will have their system of support, and then they support the learners.
There will also be an opportunity when they are doing the weekly webinars, because I imagine there'll be somebody on the board for each of the webinars supporting. So, you know, if the questions need to be raised, there'll be enough opportunity to do it. And our contact details are always on the web anyway.
Yeah.
Okay. But it's a fair question, because you're right, they will ask.
Yeah.
Somebody.
I'm trying to think what they will ask.
Yeah. So can you, while we're on the call, can you think of anything else that people are likely to ask?
Emma's wanted to come in, Jeanette.
Right, Emma. Speak.
Hi.
Hello.
Hiya. Hiya. I just wanted to check. We've got some RSCNs that will probably
Yes.
want to do the bigger PEDS 60
Yeah.
unit. If they choose in a year or two then to do the adult unit, you mentioned the PEDS, the adult nurses will have a condensed 20 unit PEDS. So will that be the other way round? Or is that on
we've been having this conversation. I think we haven't, just correct me if I'm wrong, but I would say we're not totally agreed on this yet.
yeah, there's not much
there is an
need.
issue.
Yeah.
No, the issue, as I see it, is that you've got to think about what people have been taught to do and what you expect them to do at work. If you're only expecting them to deal with PEDS and your unit is such that that's possible, then that's one thing. If you're expecting them to look after adults as well, then actually we've got an issue, and I've certainly dealt with this issue myself at work. How do you teach a PEDS nurse everything they need to know about adults quickly? And it's a tricky one. It's a very tricky one. The A&P, we can do a bit of variance stuff on. That's not too difficult. But then there's an awful lot of pathophysiology that's very, very different in adults compared to children. So I think we haven't quite got an answer there. So if you can dodge that question for a bit longer, please, Emma, that will be helpful.
What do you think, Emma? Do you think that they ought to have a condensed version or do the full adult?
Well, how we do it in our department is tailored more operational and service delivery. I wouldn't expect them to be able to work in majors like a majors adult nurse would be able to, because there's too much knowledge and learning that they would, and they're well out of their comfort zone. So how we tend to do it is they can work in minors because they've got a lot of transferable skills for the practical minor injury stuff. Some of them do help out in triage as a second nurse, but again, they're mindful about what they can triage, and then they act as a second or third nurse in resus or as a runner in resus. So it's more operational decided. Right. They do ILS.
Okay.
And they do some of the generic majors induction stuff like bereavement and trauma and major incident. But they don't do everything that the majors nurse would.
So we probably are not going to do a shortened program that would deliver on that, because we would be expecting, if they are picking up on adult competencies, that they are able to deliver the same as the adult nurse,
and they're not
in the same way as when we have adult nurses working in PEDS. We don't say to them, you do less of a job, do you?
Yeah.
No, you never say that. You
expect we don't. We expect them to deliver on at the same standards.
Horrible. Yeah.
Yeah. So that's the sort of debate that we've been having, is although we can do it for the pediatrics, can we do it for the adult? And that the jury's open at the moment to a verdict, really.
We are struggling to see how it would be achievable for everything. But hey ho. Any other questions, anyone? No? Okay. Right, now John says, are you sure there's no more questions? Have I missed a hand go up at all?
No.
So everyone's been very, very quiet today.
I mean, the other thing I think that I probably should point out to you, I don't know how many of you have used the facility that if you're doing a piece of work, that you can click on the button now that records it for you, so you can speak what's written on the screen. And it makes it much quicker than having to type everything out. So if you are doing a case review, then what you can do is you can dictate it straight onto the screen. Certainly the latest versions of Word have it. So it makes it much simpler, much quicker. So it doesn't you don't spend all those hours having to type. especially if you don't touch type.
There's a variety of things we can do there.
Yeah.
Right, now,
with how does the
Great.
voice recognition work? Because usually with voice recognition software, it takes a while for the computer to get used to your voice.
Mine hasn't, Fiona. I've got a really bad Welsh accent, as you can hear.
yeah, you have.
I've started doing it, and it's picked it up really, really quickly. There's the odd word.
Yeah.
It's done it really quickly for me.
That's good. Some of the older packages, it took ages for it to recognise your voice.
Yeah. And the other thing you can do it on, and I have done it, is, you know, when you were using your phones and you're texting, in some ways the iPhone is quicker than what it is on Microsoft Word. So I've used that, and I've done it before where I've had to review something, and I've been sitting in the bath reviewing it and dictated the notes, so send myself a text, and then you can cut and paste it into whatever you want to. So it works really well.
We'll have to have a lesson. Julie.
Just some tips, yeah. Just some tips. It works ever so well.
Technology lessons.
Yeah, we will.
But it's just trying to think of ways that will make it a little bit quicker and a little bit easier for people, because otherwise you kind of feel you're spending a lot of time on things, and it all feels time consuming on the technology rather than learning how to actually do the job that you've been assessed on. So it's got pros and cons.
The other thing, of course, we haven't mentioned is case-based discussions. So if you are in the workplace and you've looked after an interesting case, if you grabbed somebody, and it doesn't have to be your assessor or your clinical supervisor, it could be one of the doctors, one of the consultants, and say, can I discuss a case with you, and get them to write it up for you, that you've shown knowledge, that you've shown, you know, your decision making's good, because that's all really, really good evidence. And it triangulates evidence for your portfolio as well.
Okay, are we all done, ladies? I was going to say ladies and gentlemen, but it's only ladies tonight, isn't it? So, are we done, ladies? Okay, that's fine. So on my screen now, she says, if I can pick the right screen. Yes, that's it from the current slide. I've got a QR code. And my instructions are that QR code will get you an attendance certificate. John says that will work. I'm going to trust him.
You've got to do your evaluation.
It's a little bit smoke and mirrors as far as I'm concerned, but that QR code should get you into the evaluation, and then once that's done, then it will produce you a certificate. So I'd love to know that works. It's kind of, I'm not too fussed what you thought of the session. I want to know whether the QR code works. Okay. Well, folks, I've because there was only a few of us,